Thank you very much for that kind introduction, Bernd, and I'd like to thank the organisers for asking me to present. So I'll be going over the paediatric and neonatal resuscitation guidelines, and please do put questions which we can take at the end. I shouldn't take credit for the neonatal resuscitation guidance, as within ERC there are different working groups. There's adult, paediatric, neonatal, and education EIT groups, which all work separately to produce recommendations. But I'm pleased to thank the neonatal group for allowing me to present. So what I'm going to do is firstly cover paediatric basic life support, note the changes, then foreign body airway obstruction in children and management, and then turn attention to paediatric advanced life support measures. There are some changes which are on the basis of evidence as gathered by ILCOR, and also in terms of practical application and knowledge previously from practitioners in resuscitation that do feed in to the European resuscitation guidelines. So the first one I'm going to commence with is paediatric basic life support. Just waiting for my slide to come up now. There is a slight delay on this, so please do bear with me. Okay. Yes, we are clicking. Ah, here we go. Paediatric basic life support. So here we go. Paediatric basic life support. So as you know, the requirement for paediatric basic life support is actually very uncommon, certainly in the out of hospital situation. And in order to advance and improve matters, as you can see, the algorithm has been adapted. So is it safe to approach, shout for help, unresponsive? And that judgment's extremely important. And if there's a second rescue at this time, then the EMS team should be alerted as soon as possible. Having a speaker function, for example, having a call dispatcher, this is for lay bystanders, has shown to improve, certainly in simulation work, the delivery of CPR by non-trained individuals. The second person may also go off to collect the nearest available AED if it is accessible, noting that relatively few paediatric basic life support events are directly of cardiac origin. However, again, AEDs may well help provide further instructions at scene if, for example, a call dispatcher is not available. So from being unresponsive, then the similar maneuvers are always performed as an open the airway, and absent and abnormal breathing pays reference not only to apnea, but also to the presence of gasping, to agonal breathing, which sometimes is incorrectly recognized by lay people as being breathing that is sufficient. Again, in the setting of a hospital, bag mask ventilation with 2 persons is recommended as being the most being the most effective way of delivering ventilation. If, however, and certainly this has been raised in these COVID times, it's felt that the bystander is unable to perform ventilation, then continuous compressions are recommended. However, most of these events occur within the home setting, and it's most likely, this is out of hospital arrest I'm talking about, it's most likely that the family would also have been in contact with COVID, if so. If there's a single rescue, call EMS, collect the A&D, if only it's a sudden witness collapse, because those are the majority of cardiac-related cases according to the literature. So after having assessed the breathing, go on to 5 rescue breaths, and unless there are clear signs of life, commence immediately with chest compressions, and then alternating at 15 to 2, as you can see, as is previous practice. So there are some alterations, as you can see, about going on as soon as possible. And looking at the evidence for this then, so there's the importance of oxygenation and ventilation, and we've removed this idea about duty to respond and seeing if people are trained in BLS. Specific target groups should use 2-person BMV for ventilation as a minimum. The signs of life only if they're present do you not give the chest compressions. Otherwise, if there's any doubt, crack on and get going with those chest compressions. And what's very important is the duty cycle. That's to say the rate, depth, and recoil are not leaning. And for a single rescue, it's recommended that a 2-thumb encircling technique for infants, that's under the age of 1, may give a more effective chest compressions. However, it should be noted that this is quite a tiring technique, and therefore attention should be paid to if there's someone else who can then take over after a short period of time to maintain adequate chest depth, rate, and lean factors. So 15:2 and limiting hands-off time. On to foreign body airway obstruction. So again, I'm sure you're familiar with this. Again, shout, ask for help. If the child's coughing, encourage, monitor for deterioration. If there's ineffective, then the back blows, chest thrusts in infants, and for the child, the back blows, and 5 abdominal thrusts, alternating between the 2 of them. We don't deliver abdominal thrusts in infants because of the location of the spleen that hangs roughly about 1 centimetre or so out underneath the margin of the rib cage. Again, there's emphasis here about having a second rescuer to call EMS and to put a speaker function on for call dispatchers. If the child should then become unconscious, you then proceed with CPR techniques. No repeated or blind finger sweeps are to be used, as this may give rise to complete obstruction if it's not present. Oops, sorry. Moving on now to pediatric advanced life support. So again, safe, shout for help, recognition of cardiac arrest, and also those who are in the stage of bradycardia due to hypoxia or ischemia. And obviously respiratory arrests have better outcomes, as we know, than cardiac arrests, but there's a very quick descent from bradycardia into full-blown cardiac arrest. So continue or start pediatric life support, minimize the number of interruptions, call for help, and attach, this is now in a hospital setting, but out of hospital, a defibrillator, AED. But then coming on to the advanced system, look at the rhythm, and it divides into the 2, as we know, shockable and non-shockable. There will be some cases where termination of resuscitation is decided upon because there is no chance whatsoever. And this is often in severe, for example, severe trauma, or the child having been dead for quite a long time, for example, rigor mortis being in place. So that's part, along with the assessment of the rhythm, is to see at the outset for the team leader to see if it is right to continue. So again, going along the shockable route here, we can see, assess the rhythm, deliver shock, 1 shock, 4 joules per kilo, and then resume CPR for 2 minutes. And then intervening, you can see here after the 3rd shock, amiodarone, and that's either IV or IO, and adrenaline. On the other arm, we've got non-shockable, which is more common. Give adrenaline as a first line as soon as possible, and then resume CPR for 2 minutes, again with minimal interventions. And we all know about the 4 H's and the 4 T's. These are very important to look for. Certainly in the ED setting, many of these can be determined quite rapidly, relatively speaking, such as the temperature, tension pneumothorax, tamponade, for example, with focused ultrasound, and a blood gas will show you many of the other features as well. There's a lot of debate about the role of adrenaline in the presence of trauma. And there are some suggested algorithms which omit epinephrine because the primary problem may well be volume loss. That's still an area of contention. There's also guidance, as we know now, for eCPR. So there are certain situations where you may need to adjust the algorithm. A lot of that will be down to local practice. In CPR, we've talked about this before, good quality cycle of giving basic life support, bag mask ventilation, initially with 100% oxygen, but I'll come on to that. Avoid hyperventilation. Access, IO is often practically easier to get, certainly than in a very shut down baby. Adrenaline every 3 to 5 minutes, flushing, after each drug administration. Amiodarone we've talked about. Think about advanced airway. If a tracheal tube is in place, then ventilate at a rate, and this is a change, ventilate at a rate that is more age appropriate. And you can see the figures here for each of those categories. Similarly, another change is that in refractory VF or pulseless VT, you may need to consider escalating the shock dose, and the maximum you can see there is 8 joules per kilogram or 360 joules. So that's an additional change to the algorithm. As ever, ABCD approach, oxygenation to control, avoid hypertension, treat precipitating causes. And the support messages from this is ABC as a common language, titrate the oxygen therapy. If you get ROSC, you don't want to have excess amount of oxygen free radical formation. And so titration will be important. Judicious use of fluids. Balanced, and there's a big argument, as we know, about the use of normal saline against other volume fluids such as plasma light, for example, and certainly in trauma, access to blood is early is recommended. Basic life support we've covered, I think, reducing the amount of hands-off time, and for the ALS we've talked about here with the ventilation rate. So up to 18 years of age, excluding newborns, the adult guidelines can be applied to those who you think look like adults. But increasingly, there's evidence that even young adults may respond better to ventilation compression system of resuscitation. That's still contentious. So at the moment, we're recommending 0 to 18 years of age for these guidelines. Do or lead procedures for which you feel competent at, and that requires training and ongoing training and assessment. ABCD manner with a team approach. And again, I know everyone, certainly in anesthesia, would agree with that. The AB then, the airway and breathing. Liberal oxygen may give hypoxemia, which can be related to, for example, free radical and even affect neurological function later on. There's no evidence to give preemptive oxygen without signs of risk for hypoxemia or shock. And again, titrating would be really important, as I say, especially those children, for example, neonates with chronic lung conditions where they're on home oxygen, because they may have altered capacity for response to oxygen. So titrate, the magic figures are 94 to 98%. If you don't have that, then yes, do give high flow oxygen, but try and titrate as soon as you can. For the circulation, as I said, and what's being understood is that circulatory failure, it isn't just one element itself. So there may be a number of underlying reasons. So in anaphylaxis, for example, there's endothelial leak and increased permeability of vessels compared to trauma where there's simply blood volume loss. Although, of course, that could also be associated with neurogenic shock. So think of the reasons as to why the person needs resuscitation. And sustained perfusion is really key. And that may mean going early to the use of vasoactive drugs. Avoid fluid overload. That's certainly been found to be a negative factor, as was suggested in the FEAST trial. I won't touch on the FEAST trial here in this talk. So in shock, give 1 or more fluid boluses of 10 mils per kilo and reassess after each bolus and think about inotropes early. Now, neonates are different in that essentially they're undergoing a transition from to an atmospheric environment from an aquatic one, and most do not need anything at all. However, there are a small number who may need interventions such as bagging, and a smaller number of that who need chest compressions, and a smaller number of that who may need inotropes as well. So the top messages from the neonatal group relates to things that are really quite basic. Delay cord clamping can optimize condition, especially in preterm infants. There is a caveat to age. Drying is really important in keeping warm. They lose heat extremely quickly, and that does have an impact on mortality. Look at the airway and breathing. A fast heart rate above 100, 120 or more indicates adequate oxygenation, whereas the reverse may indicate bradycardia because of hypoxemia. Simple steps to support airways and breathing does most problems, and chest compressions are only effective once effective ventilation is established with a bradycardia. So the key recommendations then. So delay cord clamping survives, improves survival and hematological and circulatory stability, especially in preterm infants. That's given the proviso that resuscitation is not required. So delaying cord clamping for at least 60 seconds is recommended, ideally until breathing has commenced. However, be cautious about cord milking, where you can't do delayed cord clamping in infants older than or younger than 28 weeks, and that's because of the cord fragility. Keeping warm. So as we've said, mortality and morbidity increases as baby gets colder, and stimulating the baby as part of drying them off improves breathing effort and oxygen saturation. And here's a temperature gauge, as you can see, about the set temperature being between 36.5 and 37.5. And there's often about putting a premature baby into a sealed bag and then putting underneath a heater. And the evidence, we've talked about apnea, heart rate being the best indication of oxygenation, and looking at oximetry and ECG. Recommendations: support respiratory, if not breathing adequately, use heart rate and peripheral oxygen monitor, frequently reassess. The targets are above 100 beats per minute and saturations greater 85 at 5 minutes and 90 at 10. Call for help early. And again, this is simply the process here about opening up the airway, breathing effectively with the pressures that are required. Two-person technique, may need to consider a laryngeal mask, gradually increase inflation pressures, and once chest wall movement, ventilate at 30 breaths per minute. So, and again, 3-to-1 ventilation, 30-minute cycles. If there's no response, increase the oxygen, reassess the heart rate every 30 seconds. Think about intubating if you can't, then the laryngeal mask, and use the UVC or IO for epinephrine, volume, and glucose. So in summary, we've covered at a gallop changes that there are in the pediatric basic life support, the foreign body airway, advanced life support, and neonatal resuscitation. I thank you for your attention.
Thank you very much, Ian, for this fast ride through a very important topic. Intraosseous has a good place in all your topics. And we have one question received from the audience, and this will be given to us by Sharon Anaf.
Yes, so there's a question from the audience, and then there's an additional couple of questions, if we will have time. So the question from the audience relates to the timing of the administration of adrenaline, where ACLS guidelines recommend earlier administration than you do. And the question, and then in pediatrics, and the question is there a reason for this difference of
Yes.
giving after 3 shocks rather than 2, and so on?
Yes, so it's on the basis of the systematic review that was worked in ILCOR, showing that there was a range of, the studies show there's a range of time of administration of adrenaline from different studies, and this is the real world environment these studies come from, and it showed that there was probably greater efficacy after the delay with shocks than not. Some of that may be because of difficulty with administering adrenaline, or epinephrine as I should call it, getting access and so on. The key thing would be the delivery of shocks. So again, I'd recommend the questionnaire to go and look at the ILCOR systematic review on the timing of adrenaline, and that's where the literature sits.
Right, thank you. That's very interesting. And I also would like to ask a question relating to the targets of oxygenation that are so different in children and in neonates. We're aware of the studies performed in neonates relating to oxygenation. Are we not doing something very almost arbitrary by defining a certain age at which we stop giving or give less oxygen, and only after in a certain age at which we would give a higher percentage?
Yes, it's a very good question. Some of it relates to the physiology and as it were, the capacity of the neonate to deal with the oxygen levels that they have. And again, don't let me teach it physiology, but there is the element of the hemoglobin F, which is predominant, and that has a different oxygen dissociation curve, as we know, to the hemoglobin A and A2. There is a tail off, as we know, of hemoglobin F, you quite rightly point out, over the first sort of 3 months or so, as hemoglobin A comes into place. Also, the various adaptations that occur in the neonatal period are fascinating in terms of the alteration to a higher oxygen content than in utero. So in utero, ordinarily, the PaO2, or arterial, I should say, saturation is about 75% uniformly, and then suddenly bursting out into the world. That's probably why the neonatologists accept, as it were, the 85 then to 90% after 5 minutes as adaptive processes. But Sharon, you're right. There's a whole range of different physiological processes, and to how do I put it? It's really trying to be as pragmatic as possible. But I think in the future, we will have different ways of dealing with different conditions, as I think you sort of alluded to earlier, as relating to their etiologies.
Thank you. And we have, I hope, time for one last question from the audience. Do you have any comments on the value of capnography in pediatrics and neonates?
From my mind, essential in pediatrics. I can't answer for the neonatologists, but absolutely essential. And that can be non-invasive as well. And we certainly use that in the ED settings. But thank you, that's a great question. Thank you so much.